Today, I'm going to talk how lung cancer screening shift our treatment, how it change our clinical practice in our surgery. Yeah, remember this is a milestone for lung cancer screening in I-ELCAP, in LCT, Nielsen, because their indication for screening is different. We can see they found early stage lung cancer is different. So the I-ELCAP, they found the lung cancer 85%, they stage one, the another one of less than 60%. After this 3 milestone study, I did conduct a study in China from 2013 to 2014. Over 11,000 population was screened. We can see that over 80% smoker and over 60% is male. Surprisingly, we found, most of them never smoker and male. It's very hard to publish this data in the, mainstream journal, but finally we published. Surprising to me, and the stage one is 80%, 70% is GGO featured lung adenocarcinoma. After this study, it didn't collect another study. So the data from 6 different hospital employee routine examination, we can see that your colleague seem like health turn out to be 2% female turn out to be lung cancer, and 1% in male turn out to be lung cancer. So young female never smoker, in this population is high detection rate of lung cancer. Another surprising is 97% in stage one and 96% is GGO featured lung adenocarcinoma. So what we're going to do, your colleague seem like normal people. How can we screening this population? I'm not going to talking about it for traditional high-risk population of every year or twice a year. So I proposed the new screening strategy for traditional non-high-risk population, low age, low frequency. We published the paper several years ago. At that time, I proposed maybe your first basic line, maybe 30 years. Just 2 years ago, I found a case, 9 years old, turned out to be minimal invasive surgery. Last year, several our colleagues that this case had family history. I say no, we don't know what the reason caused in the non-high-risk population, why is so high detecting rate for GGO featured lung adenocarcinoma. So new epidemiological characteristic of lung cancer, young, female, and never smoker, high detection rate, a GGO type lung adenocarcinoma. So according to what we found, we proposed a new screening strategy. So low age, low frequency. If the baseline negative, you can have another one 10 or 15 years later. So what the GGO? The GGO may be benign, maybe lung adenocarcinoma. So how to improve the diagnostic accuracy is the key. I think that this the what we found, over 15 years. The first 10 years, very slowly. We cannot say, oh, this is the tumor, but indolent. After the solid component come up, it's growing very quickly, until 4 years, first 10 years very slowly, but after the solid component come up, it grew it's very quickly. So it turned out to be an adenocarcinoma. And second one, Yesterday I saw, our colleague presented the case, for over 10 years, they don't cure. But this case is not lucky. We found that in 2014, I think it's curable. It mixed GGO, and 6 years ago turned out to be stage 4. We biopsied the patient and adenocarcinoma, Herbert EGFR mutation. At this stage, patient under the drug and the multi-therapy still have the opportunity to survive for another 5 years, but very hard. If 6 years ago we treated with the surgery, maybe patient survival for a longer time. So the classification of lung cancer nodule, GGO maybe disappeared. After the pandemic, we know GGO maybe just inflammation in the lung. Cell days, it will disappear. That's benign. And some GGO with decrease in density and persistent forever. We don't know what that is. And also the pure GGO, they can enlarge. They can become some solid component come up. Most of them is in malignancy, and solid nodule, another story to talk about. So keep in mind, persistent GGO slowly growing over 95% turn out to be malignancy. This is a study we published in JTO in 2019. We defined GGO component lung adenocarcinoma, defined as special clinical subtype. And also you can see even in stage 1, their CT imaging different. We can predict their different prognosis. And also we did a study from age until stage 4, that over 1,000 pieces of cases. We know GGO type lung adenocarcinoma. Already, their tumor, they are lung cancer, Herbert EGFR mutation, and KRAS and ERB2. Proportion of the tumor suppression mutation in the GGO type lung adenocarcinoma is significantly lower than solid tumor. And also GGO type adenocarcinoma exhibit fewer tumor mutation burden, CMV burden, chemosome structure variation burden, and the whole genome doubling event is lower than the solid tumor. So we can summarize the GGO type lung adenocarcinoma is special clinical subtype and also special stage of its natural evolution. At first, it's very indolent, maybe lasted over 10 years. So it's not we cannot ignore that it exists. We need to keep in mind this is lung cancer. So we can conclude GGO type lung adenocarcinoma special clinical subtype, and also it's a special stage of its natural evolution. So I think that's our common practice for the physician. We can see the patient come to your office and to your clinic with the CT imaging like this, and we can do a lot of examination. And this imaging maybe turn out stage 1, maybe turn out to be stage 4. Now we can, according to the stage, we give a different treatment. Now a lot of patient with the image like this coming to our clinic, and maybe they are pre-invasive adenocarcinoma. What are we going to do? If we tell you the first one, they are the same patient, same 2 patients, 6 years ago, CT imaging like this, and the second one is 15 years apart. They are different CT imaging. What are we going to do? Even yesterday here, we are talking about overdiagnosis and overtreatment. And we don't treat it in the early stage, and we treat it until they progress to the later stage. I say no. And it's not treated or not, how do we treat it and when we treat it. So I think in 2011, there are 2 important things happened. One is the NLT result come up. Another one, I-ELCAP pathology proposed the new lung adenocarcinoma classification. It very help us to define not just the benign or malignancy. It tell you the early stage or not. So we try to use intraoperative fluid section to guide the sublobar resection. Until the 2015, we collect over 800 patients. Intraoperative fluid section compared to the final diagnosis, 96% is accurate. And over this patient, 50%, we do the sublobar resection. And there are 5 years DFS 100%. And the result published in JCO, and the JCO also combined with editorial, additional step towards the personalization of surgical care for early stage non-small cell lung cancer. And in 2017, it adopted by the ESMO guideline. So we there are the 3 studies. First study, we produced the same result as JCO result. And the second one, we follow up until 10 years. There are 10 years DFS 100%. And the third one from Japan National Cancer Center, the same 5 or 10 years DFS rate 100%. So we can see that pure GGO, ASMA, lipidic dominant adenocarcinoma, 100%, 5 years survival rate without after complete surgery. So some of the other type lung adenocarcinoma might be cured, but we cannot be predicted individually. So we proposed the concept of creative time window for surgical treatment of lung adenocarcinoma. The definition is 5 or 10 years IFRS or DFS 100%. We can, before surgery or after surgery, we can 100% sure. Without car accident, you can survive, another 5 years or 10 years without the recurrence. Why we creative this time, the new concept? Just try to seize the opportunity to cure the patient and also to avoid overdiagnosis and overtreatment. So how to avoid overdiagnosis and overtreatment? So the firstly, you need that's the tumor, that's the malignancy, not just the benign. So persistent and slowly growing, the accurate rate is over 95%. And also the second one, we compared estimated life expectancy versus its natural evolution. If the first one greater than the natural history, we can diagnose it and treat it. The second one, if the estimated life expectancy less than natural history, we just leave it alone, just let patient be. The third one, how can we avoid overdiagnosis treatment? We can see the study where the first study for the ASMA, lobectomy 16%, and second one, in still our data, is 36%. The third one, that's a long time ago from Japan, that's the data from 1998 until 2010, that's a long time ago. So at that time, over 50% of the early stage, they do the lobectomy. I think, you can treat it gradually. You do the segmentectomy, that's overtreated. You can treat it segmentectomy, you treat it lobectomy, that's overdiagnosis, overtreatment. So I think it treated the patient, just to give right surgical treatment and also minimally invasive. That's the surgeon talking about minimally invasive. We try very hard to minimize the size of the incision and minimize the number of the incision. And ultimately, uniportal is the best. Do you think so? Yeah, that's the surgeon talking about. And our radiation oncologist, hey, see, there's no incision there. You're talking about minimally invasive. We're talking about no invasive. You cannot see a incision there. So that's not the key. So I proposed a concept of minimally invasive surgery 3.0. This is published in 2020 18 in annual surgery. Minimal incision, minimal resection, that's the key. So we try to keep as much as possible normal lung parenchyma and also minimal systemic damage. With the good or bad of your surgery, just not in terms of incision, the size or the number. We should, evaluate our surgery in terms of the patient live longer and live better. So according to the new feature of GGO type lung cancer, we optimize the preoperative workup for the patient like this. We don't have to do bring MRI, bronchoscopy, PET scan. It doesn't work. It doesn't have to make the decision. And there are several retrospective study and prospective study to verify this, what we're finding. And also we proposed a selective mediastinal lymph node dissection. Even today, all the guidelines still recommended you need to dissect it as at least 3 stations of mediastinal lymph node dissection, mediastinal lymph node. And we the first we proposed in 2017, and last year we I made a review article in published in the GTO. So we need for the early stage, we don't have to do the media. We call omitted mediastinal lymph node dissection. The second, selective mediastinal lymph node dissection. We cannot predict just do the systemic mediastinal lymph node dissection. And we do some retrospective study to meet the data. Then we do a prospective study to verify this requirement 100% accurate. This is published in the GTO 2 years ago. And this is a pretty review. It published last year online. We can see even less than 3 centimeter before we do a lobectomy plus lymph node dissection. Today, depending on the different location, GGO and the CTR, we can do a bunch of different procedure for the patient, just to make sure our patient, avoid our patient over treatment. So, and also for the patient like this, we don't have to ask our patient to come to our clinic every 6 months within the 3 years. And after that, 1 year, once a year. In early stage, the patient come to see me in office. Yeah, you can come up to see me 2 or 3 years later. It don't have to, because we know there no recurrence in the 5 years or in the 10 years. So the follow-up strategy is individualized. So we can see screening detect lung cancer is the proper timing for surgery. And before we're seeking the curability. And even stage 1, we try to separate it. We know, this kind of patient, you don't have to see me every 6 months. And in another stage 1 to 3A, we try to improve our survival rate. And 3B to stage 4, and that medical oncology seeking become that the stage patient to a chronic disease. So this is our treatment algorithm for the key for surgery is minimally invasive surgery 3.0. According to our individualized strategy, we can see our 5-year survival rate. Even we reported 10-year survival rate, at the best forever. So we summarize imaging the characteristic of lung cancer epidemiology in China. Now we know not just in China mainland, in China, Taiwan, and Hong Kong, and also South Korea and Japan. So young female never smoker population with notable prevalence of GGO featured lung adenocarcinoma. Screening strategy, low age, low frequency, and GGO type adenocarcinoma represented distinct subtype and the special stage of its natural evolution. Curative time window, avoid overdiagnosis and overtreatment. The concept of minimally invasive surgery 3.0, intraoperative prudent section to guide the sublobar section, and the selective mediastinal lymph node dissection, and personalized postoperative follow-up strategy. Thank you for your attention.